Welcome to AETCM, the Emergency Medicine channel. Today I will be presenting an oncological emergency that presented to our ER. A 68-year-old male patient was rolled into our ER with complaints of generalized weakness since 1 month and altered sensorium since 1 day. Initial 10-second assessment, patient was not obeying commands, but patient was conscious. Then primary survey, his airway was patent, there was no pooling of secretions or guggling or stridor. Breathing, his respiratory rate was 20 per minute at the saturation of 99% in room air. Bilateral air entry was equal and chest exertions were normal. Circulation, his BP was 110/70 with a pulse rate of 108 per minute and MAP of 80. And CRT
80 or 108?
80 mmHg.
Okay.
CRT was less than 3 seconds. Disability, his GCS was E4, V3-4 and M6. Pupils 2.5 mm bilaterally equally reactive. His temperature was 101 degree Fahrenheit and GRBS was 108 milligram per deciliter.
In an oncological emergency case, the temperature is like this. What is the first diagnosis you will think? I'm not telling that is the diagnosis. What is the first diagnosis which will come to your mind?
Neutropenic sepsis.
Okay, that should be the first one. Okay, whether the neutrophil number is low. See, textbooks have given when the number is low, you are prone for infection. When in leukemia, the numbers may be high, but that also should be considered as an infective process because the numbers are very high, but these cells are unable to tackle an infection. Functionally, they are deficit. So, if you go according to textbook, then it will be difficult to treat this patient. But when in leukemia, case of leukemia, cells may be very high, the count may be very high, but they are prone for infection because these cells are not able to control any infection. So, that should be kept in mind.
Adjuncts to primary survey.
You want to do anything at this point of time? Somebody with altered sensorium, 101 fever.
Anyway, hyperglycemia is ruled out. We need to insert 2 large bore IV cannulas and we should give paracetamol injection.
Okay, paracetamol is not an emergency, but we can give. Please continue.
Where will you give IV paracetamol?
IV
parenteral paracetamol.
IV paracetamol is usually indicated in case of febrile seizures condition, then pregnancy, then MI, then stroke, IC bleed.
These are the important conditions where you give immediate paracetamol. You should not wait for anything. Here you have time, but you have given already. It will control the symptoms. Patient will be symptomatically better. Tachycardia will come down. So advantages are there. Okay.
Hyperthyroidism.
Adjuncts to primary survey, blood gas analysis was asked, sir. His pH was 7.
What is there in your mind when you are asking a blood gas analysis in this patient? What do you want to rule out?
He is having altered sensorium, so we need to rule out our ABG is showing electrolytes, so we need to rule out any hyponatremia is there. Then carbon dioxide built up, whether because of carbon dioxide narcosis it is there, and even metabolic acidosis can cause altered lactate.
Saturation is normal. According to your previous diagnosis, it was normal. So can this patient develop the carbon dioxide buildup when the saturation is normal?
Unlikely.
Respiratory rate of you said 20.
Normal.
And PO2 you said SpO2 you said 97.
With this respiratory rate, we are expecting normal.
Your previous clinical diagnosis, this patient does not require an ABG, but since we have additional values in the ABG mission and we get it very fast, we are asking for an ABG. Otherwise, this patient as such, your clinical description does not require an ABG diagnosis. You may get lactate in this, you may get creatinine, you may get electrolytes like sodium, potassium, all these things. These are the advantages. Okay.
Altered sensorium with metabolic acidosis. What all things you will keep in mind? Suppose this ABG, you have asked for an ABG and you are finding a metabolic acidosis.
It can be because of renal failure, elevated urea. With renal failure can cause uremic encephalopathy and metabolic acidosis. The toxicological causes, alcohol, and then decay.
Toxic alcohols.
Decay.
Sepsis. Lactic acidosis.
Lactic acidosis, will it cause altered sensory?
It causes sepsis.
What is that?
Hypoperfusion can.
No, it can produce, sepsis can produce. Lactic acidosis never produces altered behavior. What you told is correct. Sepsis will produce what it is called as
Septic encephalopathy.
toxic encephalopathy. Septic encephalopathy, toxic encephalopathy, both are same. Okay.
When you are asking for an investigation, you should have some differential in your mind.
Okay.
That is a point.
So whatever investigation you ask, it's okay. But we should know why we are asking. Otherwise, we'll miss it. Because we'll ask, routinely we are asking so many investigations. If you are not knowing what you are looking for, you'll miss it. Okay.
So this patient's pH was 7.384, PCO2 was 31, bicarbonate was 18.4, lactate was 2, anion gap was 14, the creat in our ABG was 3.77 and sodium of 132 and potassium of 5.
Okay. What do you think?
It is a high anion gap metabolic acidosis.
You can't say it is acidosis now. You want to add one more word.
Compensated metabolic acidosis. Maybe because of renal failure. Potassium is also 5, so renal hyperkalemia, renal failure.
Only metabolic acidosis? Compensated as metabolic acidosis?
Lactate is 2.
PCO2?
PCO2 31.
What is the expected PCO2 for this patient?
Expected PCO2 will be coming around
18 plus 8, that is 26
6
plus
plus or minus
It
8.
is 32. Here it is.
31.
No, it is high. Actually, how much should be the PCO2? Tell me. Value.
18 plus 8 plus or minus 36. Around coming around 38.
38, 36, 38. That should be the PCO2.
This is 31.
31. So,
Some washout is also there.
so what is the complete diagnosis?
With the respiratory alkalosis. Maybe because of metabolic acidosis, he is having
Metabolic is compensated metabolic acidosis with the respiratory alkalosis. What could be the reason for respiratory alkalosis in this patient?
acidosis. It's
No, what is that? What else he has now? What will
In
be the fever?
acidosis, what you told is acidosis, the part of compensation is tachypnea.
fever.
But here something else is there to produce more breathing.
Fever can cause
Then
sepsis.
some elderly male is coming to you. What is the common reason that he can have? Can have some chest infection.
Chest aspiration.
Some chest infection will be there. So ABG, when you are asking for an ABG, you should analyze it properly and you should find a reason why he is having all those things. It is only what high anion gap metabolic acidosis. You want to calculate anything else in high anion gap when you get a high anion gap metabolic acidosis?
Delta gap. Delta gap also.
So what is the delta gap?
Delta gap is change in anion gap by change in
what is
bicarbonate.
the ratio, how is it coming here for this patient? When you are preparing, you should have everything ready. You can't just say this pH and just run away from that. You have to tell it is a compensated metabolic acidosis with respiratory alkalosis, and you have to find out there is a third disorder is there. If it is high anion gap metabolic, again you have to calculate the osmolar gap also.
Yes,
So then only that ABG reporting will be complete. When you look through that ABG itself, you will get a diagnosis for this patient or any other patient.
Yes,
If you have a clinical picture with ABG, you have to correlate. Okay.
Yes, sir. Since his potassium was 5, we took an ECG, sir. ECG wise, it was showing only sinus tachycardia. There was no ECG, hyperkalemic ECG changes. Sir.
What all changes you can get normally?
Tall T wave can be there, sir. QRS prolongation, PR prolongation can be there. And in severe hyperkalemia, there can be sine wave pattern bradycardia.
Is it a must to have ECG changes in all patients?
No, sir. Chronic patients and all ECG changes.
Very difficult to get. Okay. What is a common finding in heart rate you get in hyperkalemia?
Bradycardia.
Bradycardia. Okay.
PR interval, what will happen?
Prolongation. Sample history. Signs and symptoms. Patient is an altered sensorium since the last 1 day. Short history was that patient who is not having any allergies or any past medications was since the last 1.5 months he was having generalized weakness, lethargy and all, and he was taking Ayurvedic medications, following which his weakness worsened. So
any of the Ayurvedic medication which is available in country can produce renal failure. There are a lot of medication, but any specific medication you want to ask? Lead containing medicine. Many Ayurvedic preparations, not properly formed preparations, contain lead. Okay, that can produce bone marrow suppression, renal failure, peripheral neuropathy. So many things can happen. So you should ask what is the drug he is taking. Okay.
Acute lead toxicity, chronic lead toxicity, both you should know. Here he is taking for 1.5 months. That's what you said.
Yes, sir.
But you have to think in terms of acute lead toxicity also.
Then after that he developed multiple fever spikes, loss of appetite and night sweats. So he was taken to outside hospital, and there they found him to be having elevated blood counts, elevated urea creat was elevated. He had some hyperuricemia, hypocalcemia, hyperphosphatemia and hyperkalemia as per the discharge summary there.
Okay.
And they did a peripheral blood smear which was showing high
So
grade
somebody is
leukemia.
having all these things, hyperuricemia, hyperphosphatemia, hypocalcemia, renal failure. What all blood malignancies and its complications can produce all these findings?
Usually hematological malignancies, especially Burkitt's lymphoma and acute lymphoid leukemia, ALL, will be producing
Multiple myeloma?
multiple myeloma.
All are possible.
Hematology.
So blood malignancies, lymph node malignancies, bone malignancy like multiple myeloma. All can produce all these findings. And Tumourlysis syndrome in a disease malignancy also can have all these findings. Okay.
It will be usually precipitated by initiation of the treatment or chemotherapy, or without treatment or itself. If it is highly proliferating, that itself can precipitate Tumourlysis syndrome.
Is he diabetic?
No, sir. No other comorbidities. Then he was treated there with IV fluids, rasburicase, and one session of hemodialysis was done, and then he was referred here for further management.
Can you tell what is rasburicase?
Rasburicase is urate oxidase inhibitor, sir. It is used as a prevention and for the treatment of elevated urate in Tumourlysis syndrome, sir.
Okay.
Usually the dose is 0.2 mg per kg is given once a day for 7 days.
Okay.
It is given. Secondary survey, head to toe examination. Head examination was normal. There was no lymph nodes palpable. There was no paleorectal cyanosis, clubbing, lymphadenopathy or edema. Then moving on to central nervous system examination, as GCS was E4, V3 to 4, M6, pupils bilaterally equal, tone, power, everything was assessed and it was normal, sir. Then moving on to respiratory system examination, respiratory system, upper respiratory system was normal and lower respiratory system, the only positive finding was he was having bilateral basal crepitations.
Okay.
Other system examination were within
Heart,
normal.
any problem?
No, sir.
Okay.
Other systemic examination was within normal limits.
Heart, what do you want to look for?
Hypercalcemia.
Examination.
Heart examination, why you want to examine the heart in this case? What you are looking for?
Malignant pericardial effusion will is.
He is having acute elevation in the urea. He can have uremic pericarditis. And infiltration, suppose it's a hematological malignancy, there also infiltration can occur after some time.
Yes,
Okay. But immediately he can have pericardial effusion, pericardial friction rupture, all these things. Okay.
So he was admitted in our ICU and he was started on IV, 2 large airway at present was patent, sir. Breathing also was at present normal, circulation is normal, and disability as of now ABC is okay. Then we went to specific management. 2 large bore IV cannulas were inserted and he was started on IV fluids. IV fluids were started, we were targeting 2 to 3 liter per day with the urine output of 0.5 to 1 ml per kg.
How is the urine output in this patient?
This patient urine output was less, even, so we started him on Lasix, furosemide was started. Even after that his urine output was lesser.
Okay.
The question is that you said 2 to 3 liters a day. See, in ICU you cannot predict any patient. So it should be depending upon the urine output. What he is making. You can't just simply give an order 2 to 3 liters of fluid a day. So he might tolerate 1 liter, maybe 1.5 liter. Hourly you need to monitor the urine output, and what is your target urine output in this patient will be 0.5 to 1 ml per kg per hour. And according to that you have to titrate your IV fluid. And again, furosemide for renal failure, how can you justify furosemide in this patient? There should be some reason why you give furosemide for this patient.
What are the indications for furosemide in this type of patients?
For urine output, then for hypercalcemia.
Somebody is having all this acute renal failure due to whatever may be the cause, we don't know. He is admitted to your ICU. You are starting fluid. On what judgment you are giving fluid? What
urine output.
See, suppose patient is not completely dehydrated. You are giving 1 liter. It will only fill the intravascular compartment and extravascular compartment. It will never perfuse the kidney or never produce urine. How can we give Lasix in this type of patients?
Depending on the flow.
You have to check the fluid status in this patient, either CVP or IVC. Whatever way you can check the fluid status in the patient. Then only try the Lasix. Otherwise, immediately after giving fluid, if you give Lasix, everything will go out. You are not filling the gaps in the body. So that should be taken care. Unnecessarily, we should not give Lasix. That's all.
So furosemide is like a big controversy itself because it can worsen the pre-renal failure again for this patient. So, sir said fluid status should be assessed first, then give you fluids. That routine practices, there is, you check any of the guidelines, there is no routine practice to give furosemide as a treatment to increase urine output for a renal failure. We are practicing it in the ICU. Maybe we will give 1 bolus and see what is happening to the output or not. But the question is, already the kidney is failing. Again, you want to increase the workload by giving furosemide. That is the question. Primarily, you treat the cause. So, what will be the cause here? It's a renal or pre-renal or post-renal?
Renal itself. Renal.
Why renal?
Because of this Tumourlysis syndrome itself, renal failure.
How do it produce renal failure?
Tubular necrosis occur because of hyperuricemia, uric acid crystals, then calcium phosphate crystals itself will be there.
Okay.
In that scenario, what should be your target urine output?
More than 2 ml. Around 2 ml.
Should be somewhat 2 ml per kg.
What it is called as? What is that process called as? How do you treat this patient? If you definitely know that patient is having renal failure is due to Tumourlysis syndrome, you give adequate fluid, then you give Lasix. It's called as forced diuresis. It's not forced alkaline diuresis. It is forced diuresis. Forced diuresis there. Another step is forced alkaline diuresis. That is in different scenario like toxicology we use. Here it is forced diuresis like hypercalcemia, hyperuricemia. You give large amount of fluid and remove the crystals which is obstructing the kidney. So that way it will help. Normal renal failure, Lasix will not help. But in this type of condition, we give forced diuresis. Okay. There you give high amount of water, you give Lasix, you try to remove the fluid through the kidney so that the crystals which is blocking the kidney can be removed. Okay.
What will be the other indication to start Lasix here for this patient?
Hypercalemia, hyperphosphatemia, renal failure.
Calcium, what is the calcium?
Calcium, this patient calcium was 9.67, correct 10.31.
Okay, so it's slightly higher. Not very high, slightly higher.
What is the usual phenomenon in Tumourlysis?
Hypocalcemia, which was there in the outside hospital report, sir. Maybe because of the correction or something, it came like this.
You have a scenario where the patient has got hyperkalemia, okay, 6.5, and also the patient has hypercalcemia. So how will you treat this?
Hypercalcemia can be seen in renal failure secondary to.
No, my question is, the patient is having a potassium of 6 and calcium of 11.
Are you asking how to treat the hyperkalemia?
Both you have to treat them. How will you treat this? The treatment of hyperkalemia with cardiac manifestation is calcium glutamate. So how will you prioritize which one is the first? That's a common thing that will happen to us. The patient can have both. The same patient is already having both. So how did you plan to correct that?
Hypercalcemia.
So which is the priority? That is the first thing. Potassium or calcium?
Calcium.
We have to correct potassium.
So the problem here is again you have to see which one cause cardiac instability. Both will cause cardiac instability, but more potent with
Potassium.
potassium. So we correct the potassium, then come to calcium. So that is the thing. You have to remember that the scenario will happen to us. Very common scenario. So which one to go ahead? It depends upon the patient condition. Suppose this patient had a seizure. 14 is the calcium. Potassium is only 5.5. Then the priority will change. You have to correct calcium and potassium. Both you have to correct, but which one to prioritize, that depends upon the patient. Okay.
Here, what may be the reason for hypercalcemia?
Maybe because of the correction, sir.
Might have already corrected. That's why the patient is having high calcium. Otherwise, normally in hematological malignancies, hypercalcemia will not occur normally. But if there is a bone malignancy, it is multiple myeloma. You can get other type of bone malignancy also. You can get metastatic lesions, lymphoma metastasis. All these things you can get hypercalcemia. Otherwise, hypercalcemia is not very common in leukemias.
Then his.
Can you attribute this to a sample error?
Yes, sir.
So how will you know it is a sample error? So somebody has taken and you are telling it is a sample error. So what all justifies that it can be a sample error from the report?
If it is going from an IV line, which is if it is an IV sample.
Suppose this patient is on a normal saline infusion. Or renal lactate, and you have taken a drip pump sample. So that is a common thing. Or you might add some potassium to it. We don't know. And there will be potassium will be high, and maybe calcium also will be high, or it can be lysed sample also. So what will be the other things that you can say that okay, this is probably a drip pump sample? Which one will help?
There will be hypernatremia with hyperchloremia will be there, sir. Then electrolyte abnormalities, even potassium.
What will happen to the other parameters like hemoglobin?
Dilution will be, HB will be.
So there will be drastic drop in hemoglobin. Some hemoglobin was something like 10 or 11. Now it is showing only 3 to 4. So always you have to confirm that it is not a sample error. When it is not fitting into the here it is fitting to the patient condition also. So you can anticipate. Means suddenly somebody is coming with all these reports. You always should have back in your mind that can it be a wrong sample that they have taken. And always check what sample it was running in.
Yes,
it can be a normal saline, it can be a renal lactate, maybe some corrections they had given. So depending upon that, you have to do.
This patient lab values, urea was coming around 119, creat was 8.46, uric acid was 8.3, phosphorus was 13.4, with magnesium 3.2. Potassium was 6, sodium 133, and his total count was coming around 33, and they couldn't count the number of neutrophils or lymphocytes in that. With a hemoglobin of 8.3, platelet of 1 lakh, and CRP was 378, and calcium, corrected calcium 10.31, sir. So according to Cairo Bishop criteria, he is having a phosphorus, elevated phosphorus more than 4.5. Calcium is according to the criteria it should be lesser. So but calcium is higher. Potassium of 6, more than 6 is important, sir. And phosphorus value also, phosphorus, calcium, uric acid should be more than 8. His uric acid is 8.3. So
even after respiratory case.
Even after respiratory treatment from outside hospital. So he is fitting into the criteria of Tumourlysis syndrome, sir. So manage.
No, but many things can see. Tumourlysis syndrome, it's fixed into your diagnosis because of the diagnostic criteria. You have to think one important thing that when the counts are very high, 30,000, 40,000, all these electrolytes can be wrong when you are taking a sample in such patients. And somebody is having a renal failure due to whatever may be the cause, he can have hyperphosphatemia, hyperkalemia, all these things. So if you strictly go according to the guidelines, it is Tumourlysis syndrome. And we have to always think about other reasons also for all these abnormalities. Okay. But whatever it is, treatment is same in emergency room.
Peripheral blood smear was asked for, which was showing acute leukemia bar lymphoma with 55% blast cells.
Okay. He's in blast crisis.
Blast crisis. Management.
So what is the procalcitonin?
Procal was 4.5. Cardiac
any skin infection, urinary infection, pneumonia, like catheter line infection, anything is there?
X-ray wise, there was right lower zone minimal opacity was there. So, maybe because of the altered sensory, mild aspiration might have occurred.
Urine normal?
Urine output was low, sir.
No, urine WBCs or anything?
Urine routine was normal.
Normal, okay.
Management wise, so we should manage after airway breathing circulation. We should properly hydrate the patient and monitor the urine output. Then we should manage the electrolyte abnormalities like hypercalemia should be
this patient does this patient require dialysis or not? That is a first question when you are taking the management.
Yes. Actually, this patient was initiated on dialysis.
This patient requires dialysis. Okay, definitely this patient we should not try lot of fluids, lot of electrolyte imbalance correction. This patient directly should be taken for dialysis because he has got a problem because of high urea, like he is in altered behavior, uremic encephalopathy. That is the indication for dialysis. Immediately we should dialyze this patient. Okay.
Along with the supportive dialysis, we should correct the electrolyte abnormalities also.
When you dialyze itself, most of the electrolyte imbalance will be corrected. Okay. But whatever it is, we have to correct uric acid, all these things. How do you manage that?
For uric acid itself, there is prophylactic management and therapeutic management. For prevention of Tumourlysis syndrome, allopurinol, that is androgen oxidase inhibitor.
But in patients who is having renal failure?
It is not, now it is not. Febuxostat
Febuxostat is another drug. Okay.
Febuxostat 40 to 120 milligram once a day can be given, sir. Then rasburicase.
Along with fluids. There also, see, when you are removing uric acid from the blood through the kidneys out, if you are not giving fluids, adequate hydration, it will go and settle in the kidney and it will produce renal failure. So whenever you are treating hyperuricemia, whatever may be the condition, fluid intake is very important.
Yes, sir. Then phosphate binders can be for hyperphosphatemia. Calcium phosphate binders can be given, and phosphate binders like sevelamer should be started 800 milligram thrice a day can be started, sir. And management of hypercalemia management either through excretion of potassium or through shift hypokalemia. So in this patient,
shift hypokalemia, shifting of potassium, it's a transient effect, and it's only in emergency. But in a patient who is having ongoing hyperkalemia, that may not work. Yes, in emergency room, definitely what you told, acute shifting is very, very important.
Since this patient's urine output was not adequate and since he was started on dialysis, so dialysis is the only way to remove the potassium in this patient.
Which all patients you will suspect Tumourlysis?
Tumourlysis in the patients who is having hematological malignancies, especially lymphomas like Burkitt's lymphomas, ALL, multiple myeloma, diffuse large B-cell lymphomas, etc. And recent chemotherapy, and who is having highly proliferative malignancies.
Like this patient was never started on chemotherapy. He presented in Tumourlysis
syndrome.
So that is also one possibility. So the patient can come with Tumourlysis or after initiation of chemotherapy also. So majority of the time we had seen the other way around. Usually we will say after initiation, but usually now the prevalence have decreased because we are giving prophylaxis.
Yes, sir.
Because Tumourlysis incidence have decreased post chemotherapy. Before they are presenting with Tumourlysis now. That's what we are saying. Okay.
INR?
INR is 1.03.
Normal. Okay. Any other issues you are facing in this patient?
In this patient, even after dialysis, his acidosis was worsening, sir. He was going into persistent metabolic acidosis and acidotic breathing.
Lactate?
And lactate was coming around within less than 4.
Okay.
Persistent metabolic acidosis and altered sensorium was worsening. So And his breathing pattern was also abnormal. He was having gasping and all. So we had to secure an airway, and his airway was secured. Then during the next dialysis, he went into hypotension, and that time his fluid status was checked. That time his IVC was 2 centimeter dilated itself. So maybe worsening of the primary condition. So, and even after dialysis support, his potassium persistently remained high.
Okay.
Just after dialysis it will be coming around 5.3 something, then it will be worsening again and again. Further on he went into arrhythmias.
Acidosis with high potassium, what else you suspect? What else you suspect? Intractable acidosis with hyperkalemia. Okay, well, here it may be due to your Tumourlysis syndrome, whatever it is. In emergency room, somebody is saying hyperkalemia with acidosis. What is suspect?
Rhabdomyolysis.
Any renal tubular acidosis? Any type of?
Any type.
Type 4 causes hyperkalemia.
So you have to read about renal tubular acidosis, especially when there is a malignancy. Many patients can have renal tubular acidosis. Okay. Some patients can have hypokalemia. Some patients can have hyperkalemia. So hyperkalemia is not very simple condition. It can have a lot of differential diagnosis. And here malignancy itself can produce falsely elevated potassium. Okay. So we should not think that hyperkalemia is not a very simple, straightforward condition here. Okay.
Then
any other drugs they are using for treatment?
Actually for this patient, the steroid treatment, bystanders were not willing for the steroid treatment, sir. So we couldn't initiate him on the treatment for the malignancy.
Part. Okay, malignancy part we should not.
Then bystanders opted out of active management for this patient. So nothing else could be done, sir. So patient expired.
Okay. Okay, thank you.